Good morning, everyone, and welcome to Looking for Healthcare Competition in All the Wrong Places. I'm Tom Miller, a senior fellow at American Enterprise Institute, and visiting today. Nice to be back at AEI on occasion. But let's see if we can get this going here. I don't even have that. Come on. There we go. I always provide a little background on this for our audience edification. This is my effort at occasional proof of scholarly life at AEI. Earlier last week, there was actually all right, I'll kill it. You get the general idea. Poor production values here. There we go. Last week, there was a webinar for continuing legal education credit, actually 6 hours. Now, I normally try to pick that up, but this one was even better. It was called Killing It in Court by a Courtroom Comedian. So I've signed up for that one and can be eligible once again for that. Let's take a look at some brief imagery of our topics today. Many of you may be familiar with this is one side of the statues outside the Federal Trade Commission. This is the Pennsylvania Avenue side. This was actually commissioned in the early 1940s through the Department of Treasury. It's called Man Controlling Trade at the FTC, one of the efforts to do various unnatural acts. Here's the other side view from Constitution Avenue, and the poor horse of commerce is saying, when does nay mean nay? It's at least a case of assault, if not more penetrating levels of criminality. And of course, at the FTC, we now have not only man controlling trade, but the chairwoman controlling trade as well. Now, the other way of thinking about this is perhaps this is actually all just a matter of riding a mechanical bull from the urban cowboy flick that you were getting the music from in 1980. All right, that's enough of the basic allusions to what's going on. Let's talk about what we're going to do today. The political market for healthcare competition operates a little differently. We're somewhat confused when it comes to healthcare in particular, where many areas of policy seem to want to limit supply, and they're a little conflicted as to what they want to do about demand. In some cases, various types of subsidies and payments actually mean that you'll want more of what seems, based on those subsidies, to cost less. So you can both get a stimulation to demand while you think you wanted to suppress demand or make it cheaper. So our policies are a little conflicted. And what most public policy does in healthcare, some changes recently, is it's mostly designed to hide the real prices rather than make them more transparent. So again, a little bit of a running in several directions at once. There's also, though, a bit of a private versus public discontinuity. Many things that are considered anti-competitive, against the law, if done privately, might not be so bad if they're done publicly. Let's take a look at a couple of examples. Price fixing. Oh, that's a terrible thing. They're colluding to set the prices, unless, of course, the biggest monopsonist of all sets the prices for you, because those are the good guys in the government. So their price fixing is good, whereas private price fixing is bad. And that's true of a wide area of administered prices as well as other types of interventions. We also have more applying one level of government down to what's called state action. Now, there's two types of state action. There's other state action which can get states in trouble, other types of liability. But this state action is a judicial construction of, you could say it's an interpretation of the Sherman Antitrust Act, liberally speaking or not liberally speaking. Also, some constitutional concerns about levels of government and who has what prerogatives. But state action basically under what started with Parker v. Brown, it's been trimmed back a little bit in the last decade or so, essentially says if a state government does it, it's okay, whereas otherwise it would be a violation of the competition laws. Now, usually the requirements are it has to be a actual state policy that can be either liberally or narrowly constructed, and that there's some type of active supervision of those who are actually doing the misdeeds. Again, we can talk about the range in which that's happened, but just think about that in terms of state action okay, private action bad. We also then have another area of antitrust law which says if you lobby for anti-competitive misdeeds, That's okay too. It's partly your free speech rights, and besides, a lot of folks have to do that and stay in business. That's the Pennington doctrine. Now, there's a sham exception to this. There are many shams in governmental policy, but the sham can be interpreted either loosely or tightly, and usually it can be sometimes said to be, well, if you're just engaged in the process of getting an anti-competitive outcome, that's okay, because someone else decided it. But if what you're doing directly causes the anti-competitive result, that might be a way in which that does not fall within the sham doctrine. So again, just think about kind of the bounds by which what we say and what we do are sometimes different depending upon who's doing it. What do we have as some current trend lines in the health competition field? We've certainly got, and you'll hear this endlessly, even more hospital market consolidation we thought was possible, even though it started to happen decades ago, but there's always another merger out there somewhere, or other type of acquisition. And those acquisitions can include buying up physician practices, which you'll hear about later this morning. And certainly the old days of the independent physician business are in the minority, and that's gotten some certain stimulus, which we'll talk about a little bit later on. We've also got employing doctors directly, not just buying their practices, and being, and we'll see whether we put on our union hard hats a little bit later on in the discussion. In addition, that's mostly to ensure referrals. It's not the doctors they want as much as their patients. That's largely hospital acquisitions, but also insurers have gotten into this, and other types of private equity operators have found some way to get into the game. All this can also be to leverage site of practice differentials, where you might get paid more generously if things are done in something affiliated close to a hospital, if not directly in the hospital, as opposed to in the doctor's office. But mostly, in addition to all that, in a world of complexities, a lot of costs to just play the game administratively, complying with various rules, even knowing what they are, getting bigger is a pretty good hedge in order to not only have arbitrage to get better prices, but also to simply comply with what it is. Now, the response to this, there could be many responses, but the predominant response, certainly in the elite circles of health policy, which I do not travel, is a growing taste for price regulation. Not just even anti-competitive enforcement, competition enforcement, but let's try a little bit more direct version of this, because someone has to bring these prices down, and it's looked like it's not going to happen to the market. We often have folks saying, you know, how should government policies respond based upon what market actors do? We don't talk as much about what market actors might do in order to respond to perhaps government policies, which are a little bit out of whack. So some of this can be a little bit of a numbers game. I like to refer to this as fantasy league antitrust, which is a way in which you can gamble on what numbers you wish to produce. You can start with market definition elasticity. If you don't like the market you have right now in order to get the numbers to work, they can be creatively reconstructed, and that's happened in the past and will happen again in the future, somewhat in the eye of the beholder. We have the formal version, which is popular with some folks, the HHI Herfindahl-Hirschman Index, which is basically taking a number of firms, squaring them, and getting to certain numbers. And we've got those thresholds going down, at least under the proposed, soon-to-be semi-finalized merger guidelines, to bring it down even lower. Now, these are constructed numbers. There are other ways to have good numbers and are actually predictable if you want to determine where you want to wager. And I would suggest that a better one is OPS, on-base percentage plus slugging percentage. We can understand that, and it actually produces a predictable result, which is a little bit more steady and more based. All right. Now, what about wins above replacement for a way in which are the enforcers actually doing better than the average enforcer? And that would be a war measure of that. I have to give some full disclosure here, because I do have a past of misguided youth when I worked in antitrust policy. So once upon a time, I actually was editor of the WAR, Washington Antitrust Report. There's Teddy grinning at you somewhat derisively. Again, limited impact, and I've made exceptions when you get into healthcare. A man has to know his limitations. And when you get into healthcare, antitrust skepticism may be not as perhaps as strong as it is in other fields. There's a degree to everything on this front. All right. What are we producing? Well, more of a new regulatory, but still unsteady equilibrium, which could go in a number of directions, but some we might predict more likely than not. We've seen it in the past, we might see it in again, regulatory capture. What starts out as supposedly for the greatest of reasons may divert into protectionism because you got to keep the folks in business who are in business, and there's a little bit of an accommodation that happens there. And if you make it very difficult for all but the biggest players to be able to handle this, the big players, the incumbents, tend to win out. So you get a little bit of a protectionist bias toward those who are already there, and they're the ones who stay at the table longest. I want to emphasize, though, this is in a larger sense somewhat fighting for market share beyond the way the market shares are derived in private markets. There's a battle between private market share and political market share. And who has more of that? Well, the government has a lot of it right now by basically running big programs and spending about half the money on healthcare. But there are ways in which you need to think about who's actually competing and what are they competing for in this battle for market share. And of course, all this is somewhat to maximize political support, put it in the framework in which that's the other market that you're trying to get by the way in which you describe this. So I would describe this as much more of a symbiosis where both parties have to live with each other. Now, there are different types of symbiosis. There's some where one lives inside the other, where some way kind of it's an option but not necessary. Parasitism is actually where one is feeding off of the other. You can't do that for too long because if you kill your host, you don't have the opportunity. But just think of this as much more of a continuum rather than a dichotomy between on one side versus the other side, who's wearing the white hat and who's wearing the black hat. Now, you can learn a lot about how to operate this in terms of collecting revenues and enforcing protection from New Jersey Waste Management. I'm not allowed to actually run the YouTube, but you can pull it up here. This is Tony instructing the boys. I know, but we're running a business here. And in many ways, if you think about that, the question is who's actually running the show. So pull it up. You'll get the 6-second version of that in that regard. So speaking of everything else that I haven't already, we have two guests today, excellent speakers. Tony Lasasso, who's going to be countervailing market power with some sporting imagery. Tony is chair of the Department of Economics in the Business School at DePaul University. He's DePaul bred, kind of like George Mikan, the first big man in the NBA, and Tony is the first big health economist out of DePaul, setting the stage for others. His work, he covers a lot of different areas in health policy, but it's always empirically driven and very thoughtful. We're going to talk today about one of the pieces he had earlier this spring in Health Affairs dealing with countervailing market power in healthcare markets. Barack Richmond comes to us with at least 3 labels today. He's visiting professor at George Washington University Law School, still has affiliations with Duke University Law School and also Stanford Medical School. I don't know whether it's a North Carolina influence of NASCAR, where they have multiple sponsors all over the car. I think it's more like the PGA, though, which is where you can go anywhere from the hat to the collar to the shirt to the sleeve, and not let alone the equipment with the different logos. The important thing is, though, which one has the position at the top of the hat. So Mark's not wearing a hat today, but I think he's probably wearing his George Washington hat a little bit more than the other ones. And he's going to be going vertical for more competition today, and we'll hear more of that in a second. Now, one of the reasons I'm doing this, and also I've got a lot of old inventory of slides I have to get rid of. We've got a little bit of the Rashomon effect, for those of you who don't know your 1950s Japanese movies, Kurosawa. This is where, in effect, different eyewitnesses to the same event see it differently because they come at it from different perspectives. And so today we've got a economics scholar, a legal scholar who also has backgrounds in economics with a PhD, but we won't talk about that at the moment, and a stand-up philosopher, all looking at different ways of health policy competition in the modern era and how we might be able to see it. Now, what would be the, speaking of where Tony's going to come first, he's going to give you some imagery as to kind of the big players, the insurers against the hospitals in terms of fighting it out and what happens. There's a different type of shape of future competition in healthcare sectors I've sometimes used in the past. Again, every old slide must be used one more time. And that's more like the heavyweights squaring off. And the question is who can get leverage on the other, or will these big sloppy fat folks just basically fall to the ground and nobody wins, and it's somewhat of a mess. But we'll work on that one. We won't get into kabuki theater, which is always misdescribed as a Japanese application, but we'll leave that out of this. We'll stay with the sumos. And on the vertical, I have to bring you memories of, this was a successor show, well, a rival to the Twilight Zone in the early 1960s. It was on ABC television. It was called The Outer Limits. Now, they had particular lingo to the beginning of it, which is, we control your screen. We control the horizontal. We control the vertical. Do not touch the dial. Early forebodings of perhaps overconcentration in the media markets. The problem with Outer Limits was they didn't know how to control their audience share, and so they were canceled in January of 1964. But it was a good show in that regard. But that's a little bit of a forecast. Now, as a skeptical, precocious youth watching these shows, when that ever would come on the show, I'd immediately go to the TV screen, grab the vertical hold, flip it around and say, so you think you're in control, which is maybe what more of us should try if we can get our own vertical holds. All right, that's enough for the moment. I'm sure more than enough you can have. Then we're going to have Tony Lasasso talk about countervailing market power and the big guys, horizontal versus vertical. Tony?
Thank you, Tom. Does anybody know what the vertical hold is? I mean, on a TV, this is well, anyway. Thank you, Tom. It's really great to be here at AEI. It's been a while since I'm here, and I'm delighted to be back. Tom's a hard act to follow, for sure. I don't have enough analogies and sports references, but I'll throw in a few. But yeah, typically the economist is here to kind of be the Captain Bring Down of the event. But so yes, countervailing. So what am I talking about here? What are we diving into? So when you go beyond the sort of textbook perfect competition story in economics, you may stumble across something called the real world, and that's where you have an industry with what we call market power negotiating with another industry that itself has market power. And so now the mathematics behind what happens in this type of situation is very complicated. I'm just going to give you a sketch of it. It looks something like this. So yeah, I could have gone sumo, but I decided to go with the boxing reference. We did not coordinate, yeah, obviously. But so in one corner, I'm not going to torture this analogy too hard, but you have the hospital industry, our friends in the hospital industry. So collectively, just as a FYI, the hospital industry does account for about 37% of total healthcare spending. So when you're banging on about the horrors of drug spending at 10%, take a look at the hospital industry and how much we're spending there. So that's just a public service announcement there for anyone who's listening. And moreover, about 80% of hospital markets in the U.S. are deemed highly concentrated by at least the DOJ, FTC guidelines as they stand today. As Tom said, those are perhaps subject to some review going forward. So we have a concentrated market. And then there is a lot of evidence, just lest we forget that concentration isn't necessarily a good thing, that hospital mergers, they raise price. We also have a lot of evidence in the economics literature showing that these concentrated markets, not only do they have higher price, but they're not necessarily buying higher clinical quality with the higher reimbursements that they get under that scenario. It generally tends to be lower. So, and here's a link to some work you can look at there. In the other corner, you have the health insurance industry. Okay, so amazingly, in nearly 80% of U.S. markets, commercial health insurance is deemed highly concentrated by those same DOJ, FTC guidelines. So, and a few more stats. When you look at metropolitan statistical area, in 91% of MSAs, at least one insurer had a commercial market share of 30%, and nearly half were a share of at least 50%. So that's at least 50%. So it could be more. And so one thing I'll just point out here, and one of the things that became apparent, I mean, it's perhaps widely known, but maybe not. But health insurance concentration is a little bit sneaky in that it kind of depends the way you look at it. So if you just look nationally, you'll see that, okay, the 10 largest health insurers, you got United, you know, they're the big one. They have 15% of covered lives. It's not called Anthem anymore. It's had at least 6 or 7 name changes, but I think it's Elevance now. But and so forth. And you look at that, you say, well, those are not particularly extreme. That's not particularly extreme looking concentration. It almost looks competitive, you might say, but it ignores Big Blue here. And so, you know, just again, a helpful link there if you're following along at home. So when you look at concentration in the health insurance industry at the state level, you get a very different sense of what's going on. So this is taken from my paper that Tom alluded to, Health Affairs, with my excellent co-authors, Yan-Chao Yang and Kevin Tuslitkowski, DePaul. And so you see here that the darkest blue here are the most where the top health insurer in the state has over 72% market share, up to as high. If you're in Alabama, you have Blue Cross insurance. I'm 95% confident of that because they have 95% market share of covered lives in the state of Alabama, and there are so these are addressed. Illinois similarly, 75-ish, 80% market share for Blue Cross Blue Shield of Illinois. So that's and just again as a note, in 40 states it is Blue Cross Blue Shield that is the market leader. So when these two, you know, get together, that is to say, when these heavyweights of the hospital industry and the heavyweights of the insurance, I would argue probably more heavyweight in certain markets when you're talking about insurers at the state level. You know, what obtains is unclear a priori, we would say, in economics. So okay, so what do we do? Well, so negotiated prices has been something that has been hard to get at for a long time. Now, however, until recently. So hospital price transparency, this gets back to a point Tom made about about prices and their observability. Price transparency was an initiative out of the Trump administration that's been continued into the Biden administration, and it has really been a kind of a game changer for a lot of empirically minded health economists. And so one of the things that you can do with basically the short version is that all hospitals and insurers have been required to provide an electronic database of all of their contract prices with all of the payers. So it is an enormous undertaking, and I'm going to send a shout out over to my friends at Turquoise Health who did the dirty work for us and scraped all these data from the websites of all of these hospitals all around the country. I tried, and it was far too big for me, even with a team of RAs chained to computers in my office. So one of the key insights when you look at negotiated prices is that, well, there's an amazing amount of variability both across hospitals and even within hospitals. So this is just a little sketch here, just kind of showing that there is a lot of variation. The blue bar, if you just look at like emergency room level 5, that's a complex emergency room visit lasting an hour or so. You see anywhere from about $500 to nearly $2,000. Across hospitals, even within hospitals, though, you see around $1,000 to $1,900 or so dollars of variation. That means that, what do I mean within hospital? That means the same hospital might have a contract with one insurer for $1,800 for the same exact procedure, and then a contract with another insurer for $1,000. So we're not in the sort of law of one price world here that some of you who've taken an economics class might be thinking about. So there's a lot of variation out there. So what we try to do then is, well, let's correlate this this price variation with insurer market share and see what we get. And so just again, very simple kind of breakdown of the states. The states that have I guess arguably the most competitive market, although that's relative in this realm, is our baseline here, all the way up to that highest level of market share, that Alabama, Illinois, the blue states that and again, this is not blue as political, it's blue-red politically. They just happen to have dominant health insurance leaders in those states, apart from the political dimension. And so you see that in those highly concentrated markets, you'll see that those insurers pay 15% less for services, and that's controlling for a lot of stuff. This is regression control. I'm still going to call it a correlation, but a very suggestive one at that. So then, in economics, we often answer, well, what happens next? Okay, so yeah, they're paying less to these hospitals. Well, where's that coming out? How are those lower prices affecting premiums, you might wonder. So here's where, I'm just going to say that I'm probably committing a number of random acts of violence to econometrics everywhere, but these are just some raw correlations, some simple data that I pulled from the medical loss ratio reporting information that all insurers have to provide to the feds. And again, I'm gonna break the country out into these three buckets here of relatively low or high concentration, relatively speaking, to the very low concentration, dominant insurers control. And the bottom line is, they all look kind of the same, right? There's nothing evident going on. At least nothing to my eye jumping off the page. Like, I don't see the market-leading insurer. That's going to be I guess it's green, the green bar, which is the market-leading insurer number one, top dog in the market. They are not, at least to my eye, obviously passing on lower premiums to their customers in those high concentration markets where we saw previously that they're paying on average 15% less for services to hospitals. I don't see much of anything here, but again, I don't want to lean too heavily on it. It's just nothing is jumping out at me. So what are my takeaways? They may be yours, I don't know, but very high insurer market share does translate into lower prices paid to hospitals. I'm pretty confident of that, but it does not, at least again, in a very obvious jump off the page sort of way, translate into lower premiums, at least that I can see. It's crude data, again, random acts of violence against econometrics, but nevertheless, nothing's jumping out at me. So we asked for winners and losers here. Tom demanded that. So so who are the losers? Well, the hospitals in these highly concentrated markets do seem to be losing out. And the people paying the premiums, well, that's us, I guess, because we're not getting, again, doesn't appear that we're getting the pass-through of those lower prices. The winners, well, insurers, namely the blues, because they do, by and large, control local markets in a big and I would say under the radar kind of way, because everybody says, well, United Healthcare, they're the biggest health insurer. Well, it depends on how you look and where you look. And then I'll just conclude by saying, it's nice to be a monopolist. You get to enjoy, you get to go home at 3 o'clock and enjoy life a little bit more than somebody who has to scrap and fight hard in a very competitive market. So there you go. If you're a young person out there, try to be a monopolist. Somebody might stop you though, Lena Khan and others. But okay, thanks very much. I'm gonna turn it over to Barack here.
Thank you, Tony.
Turn over myself here. Thanks very much, Tony. This is great. So the title of my talk is Restoring Vertical Competition. There is, of course, an oxymoron, an irony in that title. It's a brilliant title, and I give Tom total credit for coming up with the title. I couldn't have come up with a better one. It takes both a comedic and an ironic mind to come up with it. And you'll see by the end, I think, and I mean this not just in a comedic way, you'll see by the end why it's such a perfect title. Those are all my PGA sponsors at the top. And
promotional consideration provided.
Exactly right. So let me just say at the outset, why is restoring vertical competition, at least at the first glance, an ironic title? Well, when we think about industrial organization, we think about competition taking place within individual markets. So when we think about parties that have horizontal relationships with each other, those are the competitors. Vertical relationships are buyers and sellers, or manufacturers and distributors. Vertical relationships are relationships that are cooperative or transactional, not element of or reflective of a competitive market. So we should recognize that the title has a biting irony to it. At first glance, it is a misstatement, and only at the end will you truly appreciate Tom's genius here. So I'm going to start with a story. The story begins with Oliver Williamson and me. Oliver was my PhD advisor. He is the founder of transaction cost economics. He was the one who tried to understand why vertical relationships often led to vertical integration. And he established a dichotomy. This is his paradigmatic book, his foundational book, Markets and Hierarchies. Sometimes vertical relationships take place in a market between a buyer and a seller, but sometimes there's vertical integration. And what he established was that there are often good reasons, economizing reasons, why there would be a vertical integration, why instead of vertical relationship being a buyer and seller relationship, it would instead be this would be a transaction that takes place inside the firm. He got the Nobel Prize in 2009, and this is how the Nobel, or how somebody characterized the Nobel Committee's characterization of why he got the award. His analysis of economic governance, especially the boundaries of the firm. He did this by bringing together economics, organization theory, and contract law. He very much was an interdisciplinary thinker, as I think healthcare policymakers have to be also. According to the Nobel Committee, Williamson provided a theory of why some economic transactions take place within firms and other similar transactions take place between firms, that is, in the marketplace. Williamson found that common ownership in the form of firms helps to solve some market failures by mitigating transaction costs and uncertainty. Now, this is part of what's interesting about his story. He was chief economist in the Antitrust division of the Department of Justice in the 1960s, and it had a very formative impression on him and his subsequent research. As he said, although the leadership and the staff of the Antitrust division in the late 1960s were both superlative, the prevailing attitude towards non-standard and unfamiliar contractual practices and organizational structures was that such abnormalities could be presumed to have anti-competitive purposes and effects. Indeed, given the prevailing price-theoretic orientation effectively disallowed economies of a non-technological kind. It could hardly have been otherwise. That economies could result from organizational and contractual design was simply outside the canon. As a student, it often was hard to understand his writings for obvious reasons. He, in many ways, is writing the way some people play three-dimensional chess. But what he's saying there is that much of the way we measured efficiencies was only through prices and not through administrative efficiencies. And if you incorporated other kinds of costs, including transactional costs, not just prices, into an economic framework, you would understand that sometimes vertical integration is really doing good things. It is economizing. And that did not meet the expectations of antitrust enforcers at the time. At the time, antitrust enforcement was very suspicious of vertical integration. But that was a really long time ago, not just historically, but jurisprudentially. And in large part because of Oliver Williamson, and especially because of antitrust influencers like Robert Bork, we now, under current law, and I think that's even as of, it's not just as of 2020, it's also as of 2023, are very permissive of vertical integrations. If a buyer and a seller want to integrate, as long as there's no horizontal competition between them, we tend to think that's okay. That's just fine. They're not creating any additional market concentration, and they must be pursuing some kind of transactional efficiency a la Williamson. And here's another way of how his theory was plainly stated. In more numerous respects than are commonly appreciated, the substitution of internal organization for market exchange is attractive less on account of technological economies associated with production, but because of what may be referred to broadly as transactional failures in the operation of markets for intermediate goods. A buyer and a seller have to deal with the costs of transactions, the costs of buying and selling, and those costs are mitigated if they integrate. So, if it's not evident already, a lot of this transaction cost logic has been incorporated into healthcare policy. The Accountable Care Organization is basically an integration of vertical elements of the delivery system. This is taken from the intellectual source of accountable care organizations, from the Dartmouth Atlas website. ACOs are groups of doctors, hospitals, and other healthcare providers who come together voluntarily to give coordinated, high-quality care to, mostly this is the Medicare program, the patients they serve. Okay, so the basic idea is that instead of doctors and hospitals being in a contractual relationship with one another, they should vertically integrate, and they can coordinate. They can figure out how to achieve transactional efficiencies that Williamson said are unappreciated market-wide. The Accountable Care Organization model became very popular before the Affordable Care Act, but was especially energized through Medicare payment reforms in the Affordable Care Act. And we had seen, starting in the mid-90s, but accelerating throughout the aughts and the teens, a significant amount of consolidation in the provider sector. A lot of this was hospitals and hospitals merging with each other, but a lot of it also was big mothership hospitals merging with out-of-market hospitals. That's essentially a vertical transaction because they're not direct competitors. And lots of hospitals purchasing physician practices. That's also a vertical acquisition. This did increase market concentration for all the reasons that Tony described. It did also increase prices, as Tony described. This is the share of hospitals and hospital systems. Most hospitals were no longer standalone, but they became part of a system. That did lead to a lot of market concentration. And, you know, we thought it would lead to some efficiencies, but it really led to price increases. So that's hospitals acquiring hospitals. We thought that maybe we could create some kind of vertical efficiencies. I'll talk a little bit about whether there were any vertical efficiencies, but we really underestimated how much these hospitals compete with each other. it might be somewhat forgivable, but we really should have known that hospitals acquiring other hospitals are competitors, and that acquisition did lead to a reduction in competition and therefore an increase in price for all the reasons that Tony said. But let's talk about hospital-physician combinations, because these are more within the paradigmatic vertical framework that Williamson described. But we didn't find any savings from vertical integration there either. In the Medicare program, we tried the Pioneer ACOs to see if there would be any savings, but really after accounting for bonus payments, there really wasn't any. There's some early savings, but in the, not even the intermediate run, in the slightly longer short run, there were no savings. We thought that giving some kind of allowance for collaboration would make the delivery of care more efficient, but it didn't. We also, in large part for the same reason, significantly underestimated savings from the MSSP program. This is another program that relied on accountable care organizations, another Medicaid program. There were thoughts that it would save over $1 billion, and in fact, it cost more money. So why is this happening? Well, another surprise is that along with the increase in vertical integration came an increase in healthcare administration costs. And Williamson doesn't predict that. The whole idea behind taking things outside of the market and doing things internally is because that should save transaction costs. So something's happening here that is contrary to Williamsonian logic. So what's happening? Well, one thing we're finding is that when there was hospital-physician integration, a lot of care left the doctor's office, left the outpatient setting, and went to the inpatient setting. So site of care payments went up. And this was in large part simply because same services that were previously being delivered in the physician's office is now being delivered in the hospital. No increase in quality. In fact, actually, there's a whole additional set of iatrogenic dangers when you go into the hospital. But certainly, we see much higher prices because if you have an inpatient payment is more than an outpatient payment. You also saw some similar shenanigans through programs like 340B. 340B is a program where if you are a safety net hospital, which I believe is now every hospital, you get some savings on the drugs that you can pay for. This also is a reason why outpatient care was brought into the hospital. And instead of seeing things being delivered in neighborhood settings and outpatient settings and low-cost settings, we see things increasingly being delivered in hospitals. Now, in large part, because of these additional sources of revenue, hospitals continue to acquire physicians and physician practices. They want a big purchasing binge starting around 2005. And I want you to just look at that green slide. In 2000, 57% of all physicians in the country were independent. And a mere 15 years later, only 33% were independent. The ownership of physician practices by hospitals has dramatically changed the physician workforce. And really, if you are to see a physician now, it's much more likely that the physician is employed by a hospital than self-employed and independent. And this only accelerated during the pandemic. As you can imagine, doctors' offices had no liquidity. Hospitals had liquidity. They just purchased physician practices. And this has happened for every major medical specialty. Well, if the hospitals are figuring out ways to generate extra sources of revenue by hiring physicians, is that good for the physicians? Well, if you're measuring in physician compensation, it's really stayed flat. There was an significant bump in physician payment the year after acquisition, or maybe the year leading up to acquisition. But physician compensation has stayed flat. The additional costs or the additional revenues that these hospital systems are getting because physicians are inside them are not being spilled down to physicians. So this is a sea change of the first order that I don't think American policymakers, American consumers, patients, American economic leaders have really appreciated. We used to have, and we used to rely on a physician industry, on a physician practice, a profession that was independent, and now they're employees. Many of them have employment at will contracts. A lot of them have non-compete provisions where it makes it very difficult to break out on your own once you are part of a hospital practice. And they get compensated based on output, on how much and how intensely they provide. It is the exact opposite of what you would want in a health system, in a payment system, in a payment strategy. You do not want a system where you are constantly paying, rewarding people for more intensive care. You really want a system that keeps people away from intensive care and manages them through preventive care. And the adverse effects are being felt industry-wide. And I have some articles here that indicate, succinctly put, that hospitals and hospital systems are losing a certain degree of their soul. It is not what the practice of medicine is supposed to be. On top of that, physicians are really suffering in non-monetary ways also. There are a number of indications that physician mental health is really declining with depression onsets and also increases in the suicide rate, much more than the general population. Somebody once asked me very recently, why isn't anybody studying labor law? And it kind of prompted me to collaborate with one physician and one labor lawyer to say, look, maybe one solution to restoring physician autonomy, physician authority in a world where all physicians or most physicians are employees, maybe that's thinking about physician unions. And I wanted to make sure I inserted this idea at AEI because, who was the last person who spoke at AEI who said, hey, maybe unions could be a good thing? When we started writing these articles, and emphasis on the word of potential, we think that unionizing physicians might potentially offer a meaningful countervailing argument for hospital dominance. It really struck a chord. So I at least want to raise this idea that maybe we will all be cheering FDR's and the Taft-Hartley Act. Maybe. But this is really what we need to do. And I'm out of time, but I'm going to do this very quickly. This is the problem that we have seen is that when hospitals have taken over physician practices, they have figured out ways to rewire the delivery system so the hospital is at the center, and it's bad from an economic perspective, it's bad from a patient perspective, and it's also really bad from a physician perspective. And what we ultimately need is to break out of the current architecture which we're in, which puts the hospital at the epicenter of our delivery system, and they control everything beneath them. We need to break out of that architecture and come up with alternatives. In many ways, the traditional ACO really locked in the hospital. There is an alternative ACO that does not involve hospitals, and those tend to have been performing a lot better. But what we really need to do is sever the hospital from our delivery system. Not sever it altogether, but it has to be at the periphery. It cannot be at the center. And we have to figure out how to finance healthcare from the bottom up, where hospitals compete with each other and are destinations, not locales, not loci of delivery. And this might mean a significant role in digital medicine also. What are the punchlines? Well, restoring vertical competition. This is the brilliant and brilliantly ironic title that Tom gave me. Well, we need to make sure that we restore physicians as an alternative to the hospital. These were not vertical acquisitions. These were horizontal acquisitions. These were acquisitions among competitors. And they were among competitors with very different delivery strategies and different business strategies. And when we thought they were vertical acquisitions, we didn't take much mind to them. But in fact, what they did is they swallowed up a really important alternative to hospital-based care. And we need to restore that physician alternative. And frankly, we need to make sure that physician alternative can win out in a competitive marketplace, and we need to dislodge the hospital from the epicenter of healthcare delivery. Was Williamson wrong? Well, vertical means vertical, and we got it wrong, not him. Hospital-physician integration is not vertical integration. It is a species of horizontal integration. And that's why we didn't see his theory bear out. Transaction cost theory doesn't account for regulatory and payment exploits. It does not account for the centrality of professional norms. It does not account for hidden payments or hidden prices. It doesn't account for not only a publicly regulated system, but even a private financing system that really is tied up very intimately with the hospital. And antitrust enforcement has to recognize this. These are not the kinds of acquisitions, hospital physician acquisitions are not the kind of acquisitions that Robert Bork told us not to worry about. They are acquisitions that cause real competitive harm. So, last bit, large health systems are causing enormous harm to the health system. This is a punchline in and of its own. They are extremely costly. They impose enormous administrative costs. They're unwieldy. They have unwieldy and complexity. They don't work for anyone. Anyone who has needed any kind of health care has seen the costs and the incompetencies of large-scale hospital bureaucracy. And it's also inflicting dramatic harm onto the medical profession. I welcome a future offline conversation, and I'll leave everybody with Oliver's Nobel Prize.
I've just been decoupled. Thank you very much, Barack. I'll point out that postdoctoral graduate students are unionizing. Now, I didn't get the opportunity when I was a research assistant to do it back in the day with my paltry payments from Duke, but it may be expanding a little bit broader than that. So we'll look for the union label as a coming attraction. It's interesting that you're almost talking about if you go vertical too fast, you might get a case of the horizontal bends, to do a diving analogy on that front. So you're not sure which is the right speed. Now I'm going to get here, continue on my journey, looking for health competition in all the wrong places. There might be another place to look, although you may have to avert your eyes on occasion, and that's more at the state level. Now, before I said, when public policy fails, how can market forces correct it? It might be a better question than the reverse, is what we often ask. But they could use a little assist from some other place. And this is a different type of vertical competition in government. When the feds aren't necessarily doing the job, the states can do worse. They've done that before, but they could also do better. So let's take a look at what might be some opportunities in that regard. Now, unfortunately, those who are advising the states often kind of have a bit of a bent-in bias by saying, well, the market's failed, so let's what can we do next? Maybe we need just some more of the usual prescription. They've got a competitive price regulatory controlling fever, and so the only prescription is more cowbell, more of the same before. That's courtesy of Blue Oyster Cult. It's interpreted by Will Ferrell and Saturday Night Live, but always a good example of ringing the bell a little bit more widely than is necessary. And I don't want to say that state policy is the end-all and be-all. It certainly isn't, but it could be a helpful addition rather than a harmful detraction. Both the states competing with the federal government, unusual circumstance, but also states competing between themselves, at least as a possibility. Now, before getting into this, you should provide the usual caution when you provide these kind of quick hit-and-run nostrums. A lot of them will be coming. It's certainly true that for every complex problem, there's an answer that is clear, simple, and wrong, courtesy of H.L. Mencken. Certainly that's a danger we have on that front. And you could, correct some of these markets, maybe with conventional weapons, but it could cost you years and cost millions of lives. Or you could, should we instead just engage in some stupid feudal gesture, Animal House style? Perhaps not. Get out of here. Another way to think about the problem of focusing too narrowly is Abraham Maslow's law of the hammer, sometimes called the law of the instrument from the mid-1960s. Actually, you can get this attributed to anybody. Everybody attributes everything to Mark Twain if they haven't done it to Churchill or to Lincoln. But Maslow is probably one of the academics who brought this out. And that's the basic idea that it's a cognitive bias in how we go about many things. So the over-reliance on a hammer as a familiar tool from the saying, if the only thing you have is a hammer, it's tempting to treat everything as if it were a nail. And certainly antitrust enforcers see a lot of nails out there. But not only does this likely to it generates savings in the wrong, swings at the wrong targets, but you might hit something else by mistake along the way with too wild a swing. So let's go on to, again, what states could do, not exclusively, but as a more neglected arena. Some opportunities to improve things at least a little bit. And you think about the clean hands doctrine in equity, which is you don't come in unless you have clean hands. So let's first clean up what they're doing before they say, oh, we're going to save the day as well. And there's a long list of items that are partly being corrected, but probably not far enough. We've had some progress, but not enough in policing anti-competitive contracting practices. The most popular one is to try to lock down on anti-steering provisions. By some counts, you can get about 20 states. They differ in the degree to which they actually do it. There are other types of anti-competitive contractual provisions which sometimes can draw state legislative scrutiny. They're called I mentioned anti-steering. Most favored nation is actually the one that has the most prohibitions on it, where basically usually the hospital says to the insurers, I got the best price, you can't give it to anybody else. But there are other ones, anti-tiering. You must take everything or nothing at all. Those are the various ways in which it happens. One of the conflicts in the states is whether they should legislate or litigate. And some states have had some success in litigation. Now, are these one-offs or do they permeate and extend? California with Sutter System. In North Carolina, my favorite monopolist where I get my care from, Atrium, ran into some problem with anti-steering in the courts and settled. We won't do it again. We didn't do anything wrong, but we won't do it again is the usual way you settle these things. So that's at least what is potentially there. There's been efforts to do this at the federal level, and there's various bills that have been proposed out there far. And there's always a conflict. Should the federal government make an across-the-board, all cases, no matter what exceptions, we're just going to preempt this, or is it better mediated with the variations through the states? So that's kind of on the contractual clause provisions. We've also got just stop doing the stuff you've already been doing that's anti-competitive. And they come under various acronyms, and some have longer histories. Certificate of need is pretty well demonstrated to be a way to keep out new entrants and barriers, and there have been efforts to do litigation, not very far on that front. And some states have certainly pulled back on certificates, and they don't do it as aggressively as they did back in their original heyday in the late 1970s. But then we have various efforts by folks who are a little bit more regulatory bent, say we can figure out this market and put in some provisions, and whether they're called a certificate of authority, certificate of public, I don't remember what COPA stands for now, not a club, public advantage. It's actually certificate of private advantage is the way it actually works out. But thank you, Barack. Any willing provider laws. All these are the type of things where the states actually being pro-competitive or anti-competitive, and most of the examination of how these work out is they tend not to work as designed. The regulators are either not as nimble enough, or as motivated to continue to do it, and ultimately the fox is back in the henhouse after all is said and done to various degrees. You could also try to expand market entry. You know, the idea is, how do you change what's happening by getting more players on the field? And we had some progress on that front. There are both multi-interstate compacts. They can get a little oversold for expanding the ability to license in more than one state. There's the medical licensing compact, which by some counts has most of the states, except for maybe 8, although I think Florida and California are holding on that, and maybe a core of about 31 are doing it more than others. But that can be overstated as to what it's actually accomplishing, where a doctor can get basically licensed in one primary state and then be able to speed up the process to be licensed in other states. One of the limitations on it, which isn't talked about as much, is the state medical boards still control the practice of medicine within that state where you're licensed. So as much as it makes it a little less costly and less burdensome, and certainly among newer physicians, it's picking up more. I think that they're getting these type of multi-state licenses. It hasn't gone as far as it truly would. We'll talk about the alternative of other types of licensing in just a second. There's also expansion of telehealth, which happened in the pandemic. A little bit up for grabs as to how much it's going to continue expanded, which was mostly boosted through Medicare coverage. A good thing. The question is, how far does it go? And there are lingering state restrictions that may revive back depending on how they deal with it. One of the more important ways to deal with this is to change a basic definition as to where the site of what the interaction is. If you simply redefine it to where the physician is rather than where the patient is, you solve most of these problems and have much wider entry. But states are not necessarily doing that as much as they could or should. I mentioned the interstate compacts, which can get a little overstated. The idea of health care without borders. If you have problems in one market, how do you have geographic competition beyond those boundaries? Now, this steps on the toes of the local monopoly of governance, which the states have. And getting back to our old state action idea, there's a little bit of a professional courtesy among regulators. You got your racket here, I got my racket over there. Let's not interfere with each other. We can all do pretty well within those limitations, and everybody else can come fall aside. But the larger dream is, what's a way to get beyond those geographical boundaries when they're being used for essentially anti-competitive purposes, even in the name of good governance? One way in which this was, well, we'll talk about crowbars and incentives in just a moment on the past. The other is, although this is always disdained by the folks who do scoring or those who kind of have better ideas, which are more regulatory and price controlling, investing assets in teeth and transparency. It's been disappointing in terms of, even when the data might be available, how much it's used by people. What we sometimes forget is they also need incentives to want to use it, which is part of the payment structure and how they're, what prices they actually face. But building a deeper infrastructure, whether it's all payer claims databases or other ways to make things more practically available, as Tony was partly referring to, is part of that process of getting a different set of players on the field who can see what the costs are and whether they might do something, and surrogate players who can also enlist that. The general idea here is to have state regulators, for a change, try to inform their constituents more about what's going on. That's hard work, but it's real work, as opposed to automatically doing the easy thing of prohibiting or foreclosing, simply saying, you're in, you're out, and we've taken care of this. But it's a different way of thinking about regulation through an information basis. Along the way, there could be some more innovation in state efficiency and value purchasing in its own health care. It can be done to a limited degree. State government employee plans are decent players in many states, and they can put their weight in a different direction than where it was. This was done, for example, in North Carolina over the last year, where they pulled the Blue Cross Blue Shield contract and gave it to Aetna. Now, I have to add the adjunct to this. The North Carolina legislators certainly had to balance out the sheet, so they followed up by then letting Blue Cross Blue Shield demutualize without much oversight. So with one hand you give, with one hand you take, and you end up in about the same place. But potentially, whether it's using state government health plans or the Medicaid program, they could become a powerful counterweight and literally put their dollars down in a different direction when things are going a little out of bounds, or even build up a newer entrant or a newer competitor than what is the existing one. It runs a little contrary to the existing political balance there. And they could spend a little less time in where they do innovate, which is in federal revenue extraction and magnification through other means. All right, what would be some ways to enlist some extra levers and crowbars? Because on this front, it's been a little disappointing, to be fair. So what could we do instead? You could get even more aggressive with more selective, time-limited deregulation for new entrants. And this does unlevel the playing field in an already unlevel playing field. It's probably easier to conceptualize this in the insurance area. It's not instantly easy to just import a hospital and have it built up, but making it easier for someone to get started, and for the early years facing less regulatory costs and administrative difficulties is a way to perhaps rebalance the field and actually begin to provide some seeding of what might be a more competitive market. Again, a different direction than regulators usually like to go. We have a problem with scoring of how much these things will save, but a more imaginative approach to waivers in the federal area for states is to think of all the combined fronts on which you might get some savings by taking various deregulatory market opening means and scoring the benefits of that as part of the offsets for what either means lower costs or more coverage as part of that process. Now, we run into the bias of the Congressional Budget Office on this front. They were out in September of 2022. They always poo-poo, well, there's not much evidence that these things will save very much because all of the academic literature by the folks who think like us think the same way, and that's the way it goes. So we need a little more work on that front, but potentially, if you combine many of these in a single, what might be the equivalent of a 1332 individual market waiver with a Medicaid waiver at the same time, put enough in the pot, mix it around, and be as forgiving as you were to Arkansas once when it had its private option for Medicaid, as the GAO found, you might be able to get it off the ground to at least find out whether you're actually getting something different. So that's a different waiver front to give it a bit of a boost from policy. Back up federal licensing. This is always kind of one of those vampire and garlic type things. There's some history on this. There's ways in which you get states motivated to think about licensing a little differently or expanding their parameters to entrants from other states. In the late 1990s, in the Financial Deregulation Act of the time, which had mixed blessings, Graham Leach Bliley, there was a concern, they mostly letting the states continue to regulate insurance, despite the other combinations they were putting forth. But there was a problem with insurance agent licensing. Agents and brokers, they're called producers normally, and this is beyond just health insurance. And so they set up a hypothetical threat. It was called NARAB, the National Association of Registered Agents and Brokers, which would go into effect if a majority of states did not make it much easier for cross-state licensing of insurance agents. And sure enough, you can get regulators to pay attention when they say, we might lose our phony baloney jobs to someone else if we don't do something. And the majority of the states did loosen up through various model acts and other type of things, that type of agent brokering. There was an effort to tighten it up further on. That never got out of the Senate, passed in the House for a NARAB too. But it suggests one of the specters of alternative federal licensing will often motivate states to begin to cooperate with each other to the benefits of their consumers by having more open markets. I've written briefly, and this is controversial, partly because most folks think you're immediately going to drugs as opposed to the rest of the markets, but the idea of expanding the concept of ERISA fiduciary enforcement to get employers in the game, a little bit motivated to be in the game, to actually carry out a little bit more transparency and enforcement of what we've currently had by the existing government channels. And that's basically to say, if you say you're a fiduciary, you're obligated to actually tell your employees what's going on. And employers could insist on a lot more if they were motivated to do it, but they usually like to blame someone else. That's a different way to say, I guess we're going to have to do this, or stop pretending that we're holding the hands of our employees because we're just taking prices and passing it along. So that's a different area in which that could be done through Department of Labor without even legislation per se, depending on their posture. A different way to diversify demand is to take it out of the immediate control of insurers. We have, for example, premium tax credits through the Affordable Care Act, and they go directly to insurers. Now, technically, you can claim them as an individual at the end of the year on your income tax. Few people do that. It's kind of after the fact. If they weren't only advanceable to the insurers who capture the money and tend to want it to be mostly going for insurance, obviously, but if they were advanceable to individuals who are eligible for those subsidies, they would begin to decide, well, maybe if I had less expensive insurance, I'm benefiting from this, and they could capture the full benefit of the subsidy. So again, that's a cross pressure. By putting it first in the hands of the consumer patient, they may decide they want it entirely to go for the best insurance they can get, but they might want to use it for other types of things that might promote their health in a different manner, or other types of things which they might care about. Again, some cross pressures on that front. The closest example to this in a very narrow way in a couple of decades ago were some demonstration programs, which some states have continued to do. It was called cash and counseling, but it was done in a very narrow realm, basically for long-term care, really non-medical services. You could use the money that you got for friends and family to assist you, or someone you actually thought did a better job. It had a pretty good record, but it had a ceiling on it, both because the money ran out and the states weren't going to replenish it. It's also difficult to train people to do this, to monitor it. You worry about fraud. But it's a concept in terms of saying, if we actually said we want to assist people for health care, let's give them some money, let's give them some information, let's give them some counseling, at least on a targeted scale where it's most needed. That's a different way to change the dynamics in how these the supply and demand of these items are going on. Most of all, what I'm suggesting to you is a need for a better PE ratio. That's the ratio between public equity and private equity. And maybe the balance could be reversed in the way we usually think of the private equity. But that's a quick look at rebalancing the scales. You've had three different, somewhat divergent perspectives. And we're not saying this exclusively fills the entire bin, but it might add in ways or expand the boundaries that are a little bit different. And in the cozy sense, I don't know whether we'll do it within the entire firm or spread it out and subcontract it. But let's depart from the podium, and I'm assuming I'm still operating here. Can you hear me? Yeah. All right, I've said a lot, too much. Barack, I left out my slide about look for the union label with the hard hat coming on top. You didn't talk as much about the other areas of competition policy with regard to doctors. So let me just try one to fill out the slate. Non-compete clauses. I've seen pretty much trashed in the antitrust literature for going overboard. Is there a way in which that could be somewhat done in a more nuanced manner with regard to physicians who have gotten their money and then want to get out of it?
For sure there is. And by the way, I take everything, I can't think of an exception. I take everything that you said as a friendly amendment. If there's a problem, so to answer the question directly, there are lots of ways to curtail anti-competitive uses of non-compete clauses, and there are a lot of them, while preserving pro-competitive uses of non-compete clauses, where I think there still are at least a couple. And to the degree that we want to address the anti-competitive problems, one thing that I've written about is non-compete clauses look very different in a world where there's one hospital in town and telemedicine is possible. And the prevailing view prevailing antitrust view of non-compete clauses is to look at every particular transaction in a precise way, given the market environment. But there are lots of ways to curtail enforcement. There are lots of ways to adjust the contractual obligations of winding up. And those would all be good things. I'll take your question as a launching point for something else. Mm-hmm. Which is a lot of health policy, a lot of competition policy is often navigating between trying to establish bright line rules. Price fixing is per se illegal, even though sometimes it might provide some kind of stability, versus trying to be very specific to the individual actions in an individual market. And most of antitrust over the last 30, 40 years has gone towards the tailored, individualized approach. And one thing that the current FTC is trying to do is to go towards broader approaches. I could be convinced of the broader approach in some circumstances. But I will say again that non-compete clauses is one of those things that are attractive for bright line rules, for broad, bold policy moves, because everybody knows what they are. They touch all 50 states. And there's a plausible policy justification for just saying we're not going to allow them at all. And the real danger of doing that, the real danger of talking about non-compete clauses is that they are really insignificant in the grand scheme of things. The reason non-compete clauses are getting news is because there are so few places to work in any place. Most markets are concentrated. And because we have an extraordinary number of physicians who are unhappy. And we shouldn't just take that unhappiness as a reflection of a restraint on the marketplace. We should take it as a significant indicator that the delivery of care has some real problems. So I would very much, might be sympathetic to a broad view of antitrust policy, making it slightly more regulatory and slightly less enforcement oriented, but you gotta focus on the right problems.
Okay. Tony, you go beyond the bounds of your article per se, which was doing a fine-tuning of, there been some earlier work in terms of what happens when, one giant goes after the other. And that's framing it in the context of over in this corner are the hospitals, over in this corner are the insurers. Well, there are a lot of other corners as well. We're looking for competition in all the possible places. Having taken what you found, which really solidifies that looking for one big guy to stop another big guy without taking some for himself doesn't look like a solution. Are there other parameters to consider or other players on the field, or is this just a matter of tweaking and having better behavior by one monopolist over a monopolist?
Yeah, no, great question. I think different ways to answer that. You made I think the point that we all kind of I think agree on is that policy generally starts with this proposition of restricting supply at the same time you're goosing demand, and so you have a problem there at the outset. So supply is restricted, and I mean I obviously I like a lot of what you're proposing that you just talked about. I mean we still have certificate of need in 34, 32 states, something like that. Effectively turning states and hospital systems into franchise operations that no competition is in effect allowed, because it is the very same hospitals that sit on the CON board and determine whether or not we need another hospital in the area. I kind of know which way they're going to vote. And of course, Illinois, where I hail from, not always proudly, but
good governance throughout the
has not demonstrated the best governance policies around CON. But so yeah, I mean certainly doing more good by doing less bad, I think, from a competition standpoint is clearly, I think, maybe the way to go. I mean, I don't know that anybody, can, however, topple Blue Cross Blue Shield of, let's say, Alabama or Illinois in these entrenched kind of market settings, but that doesn't mean I want to give up on the concept of it. And so, entry and maybe some of your ideas about, I don't know the North Carolina example you talked about, but just the state kind of voting with its feet and trying another insurer instead of the dominant player in the state. Maybe that could get some mileage. So yeah, I mean it's really tough. I was gonna, I guess if if I can use that as a springboard in a tangential direction, but to one of Barack's point, like I guess my question would be around, hospitals being, physicians being unhappy, because I've done some work on physician labor markets. I've published another number of papers on how the physician labor market is changing, and I do think that there is some striking shifts in the preferences of physicians. I mean, we're not in this, it has been a long time since Marcus Welby, hung up his shingle outside. So we're, yes, if physicians don't want to be owners. They want it's not really a 9-to-5 job, but they want something approximating that. They prefer predictable hours, limits on call, maybe limits on weekend work. They basically want, in many cases, a job. And as we've seen from work that was recently highlighted in, I think the Washington Post, from Josh Gottlieb and others, it's a pretty good job. They make about, on average, $370,000 a year. So on the
Especially
one
if you
hand,
get your medical debt,
I
debt
know.
forgiven.
And so you do wonder, well, what are they so upset about? But nevertheless, we'll give them the benefit of the doubt. So I guess how do you reconcile, I think, what I perceive as really changing preferences for greater stability, predictability, and just a desire not to be entrepreneurs. They don't want to run a business, and then the just massive economies of scale of the physician practice these days. That you just need to have scale to be able to exploit the economies, and a solo practitioner in most instances, partner solo practitioner is not really going to be able to compete.
Yeah, so part of the problem is that we train doctors in the wrong way. We don't train them to be managers, and every doctor now needs to manage an office, need to manage. The only way to achieve that kind of scale is if you supervise a bunch of PAs and RNs. We need to make sure that doctors have a good understanding of policy. A lot of people graduate medical school without really having a working understanding of what Medicare is. And in many ways, medical education continues to foster this distaste of thinking through organizational innovations and changes and being entrepreneurial. A lot of this is rooted in professional values, but a lot of it is rooted in just ossification. And we don't train doctors the way we should be training because we still rely on, biochemistry as being more important than understanding how to manage a staff and how to understand the social determinants of health that really are affecting patients much more so quantitatively than their biochemistry. So there are a lot of problems that we encounter because doctors, once they start entering the prime of their career, they are encountering a marketplace and a regulatory environment that they really were not prepared for. Having said that, I think that it might be true that doctors, for the most part, don't want to be managers, don't want to be entrepreneurs. But I do think that the integration of the swallowing up their practices has largely been fed on the sale of a lot of false goods. And I think a lot of them regret it. There also is the political economy of the medical profession, where you have senior people cashing out right before they retire, and younger people who have 20, 30 years ahead of them having less of a say. But it is really undeniable that I think two things are happening, two things that we have to confront. Number one, we have a regulatory, payment, and cultural infrastructure that relies on medical discretion, medical autonomy, professional autonomy. Now, I agree with Tom a lot of, who are the professions? I'm a big fan of scope of practice changes, and to the degree that we can empower other kinds of medical professionals, I think that would be huge. But we have an infrastructure that is built upon the presumption of this professional authority, and that professional authority just isn't there anymore. The authority is now with the accountants with the little green hats. That's where policy is being made. And we're encountering a lot of unintended consequences. And we're still going down this path that I think is enormously destructive. And I do not, this is the direct answer to your question, I do not think this is the product of well-informed medical decisions or economic decisions by professionals. I think it's a series of false goods, regretful decisions, and situations that are very hard to get out of.
Okay. I'm contractually obligated to see if there are any audience questions, and we'll recognize them. Go right ahead. Bring a microphone over and briefly identify yourself for the essay.
I'm Hugo Gurdon from the Washington Examiner. I wonder if you would all just briefly talk about the level of political will for change, whether at the federal or at the state level. You described prices going up and services going down, and physicians in depression. And to what if you had to score it out of 10, and 10 being the point at which something is actually done at various levels, where are we in the state of concern about the problems that you've suggested, both at the federal and at the state level?
So I would answer, okay, I'll say a 7.5. Okay, so why do I say a 7.5? The enormous difficulty of making changes, even really rudimentary changes, a lot of what Tom is describing, a lot of what I'm describing, are not earth-shattering stuff. To some degree, what I'm really saying is just we have to undo some mistakes of really just the last 10 years. It's very doable. You're asking the political question, and much of Tom's presentation was talking about how integrated the economic domination and the political domination are. They certainly feed into each other. And I will give you a very stylized framework. In most counties in America, the hospital is the largest employer. The hospital, therefore, has an outsized role on the Chamber of Commerce. The good news is when the hospital hires more people. Bad news is when the hospital has to fire people. That is the political story. But that's the political story that I think we can and need to and will change. That's why I say 7.5. There is a broad recognition that the interests of the broader economy are not the same as the interests of the hospital. There is a growing recognition that the rest of the Chamber of Commerce has to act contrary to the interests of the hospital because their healthcare costs are going up. They can't afford to hire people. The whole county, including businesses, are just losing resources to manage a viable economy because the one county hospital is sucking up all resources. I think that is a reality and a political story that's becoming more transparent. And that's why I say 7.5.
I can't remember.
Jim?
Where were you?
Oh, go ahead.
I don't know if we were all going to respond or not, but Barack nailed it.
We'll squeeze one in because we've got about 3 minutes.
Yeah.
Very quickly, Jim Capretta from AEI. Thank you. Very interesting conversation. Your conversation is a lot about restoring competition and et cetera. I mean, do we anticipate that this is going to happen through the regulatory FTC, DOJ system? Or is it a political intervention telling the regulators we need to go in a different direction? I'm a little bit confused about if it's relying on the administrative agencies. I think we're looking at another 20 years before they turn themselves around. If you think they could be a political intervention, I guess you're assuming Congress, maybe the states, as Tom said. Talk a little bit about that.
I would just, sort of kind of combining the two questions here, both of which are great. I think I don't know, I spoke about 2 weeks ago to a group of state legislators at a National Conference of State Legislator meeting, and they were talking about what to do about basically PBMs and drug prices, and that's why I just wanted to make that point at the outset of my talk. Like hospital, 37% and growing.
And growing.
And physicians is another 24, 25% and growing.
That's shrinking.
Drugs,
Hospitals are growing.
Yeah,
Sorry.
drugs are shrinking. Out-of-pocket spending by patients for drugs. Yet, what always sucks the air out of legislators? They had to do something about drug prices. And I just think they're just, they want to score points. I mean, this is, again, not earth-shattering, but, they want to score political points, do something, what they perceive as concrete for their constituents, and that might be just, a lower co-payment at Walgreens. And then, who really knows or observes what's being spent at the hospital? That's third-party payment. We don't see it. We don't feel it. Yes, we complain then when our premiums, but even that's not really salient because we don't really feel it either there. So I forgot. Was a big number meaning that there's not much will, or a low number? I don't know. Whatever the number you said for, I don't think there's much impetus for change at either the congressional or the state legislative level. Hate to be a downer though.
In 15 seconds, I'll just say that as it relates to hospital-physician mergers, the FTC could make that a priority today. And, they might. The evidence is mounting. And I think that would be really significant.
I would just caution that crystal balls are a little cloudy. If we go back about 25 years, we thought that hospitals were on the sidelines and the insurers were just so dominant and they were the problem of concentration. And that changes over time depending on who's in your gun sights. But at a minimum, we could throw the old rascals out and throw some new rascals in. At least mix the pot around a little bit. We're at the end of our time now, and as I usually say on these occasions, if you've had half as much fun as I've had twice as much fun as you. Thank you very much for attending, and thank our speakers.